So before we begin our meeting, I'd like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Eora people of the Eora Nation and pay my respects to the elders past, present and emerging. I further acknowledge the traditional owners of the country on which you are on and pay respects to their elders past, present and future. Thank you. So we're here tonight to talk about the keratoconus and dry eye Save Sight Registry, Save Sight Registries. Himal, if you could please advance the slide. So welcome to the webinar. The next slide, please. We have a financial disclosure of our funders. Next slide, please. And we have assembled a range of speakers, and they're all well qualified in that area, and they will provide you with different insights on the registry program and how to monitor your patient outcomes in everyday practice. Next slide. So the purpose of the webinar is to really illustrate how you can evaluate the outcomes of patients with keratoconus and dry eye in everyday clinical practice, and that's in your practice, and to update what's happening in general with our registry program. Next slide. Now, this is some of my research team here, and you'll be hearing from them during this webinar. But the basic thrust behind the registry program is to use new knowledge to make sure we have better practice and ultimately improve patient care. Next slide. Now, the registry is supported by quite an extensive team, and amongst this team, there's specialists in various areas, including IT, ethics, biostatistics, and you'll be hearing from some of the team tonight. Now, why a registry? Well, in clinical trials, patients are recruited with very strict criteria. And so the patients that are in clinical trials, like Miss and Mr. Perfect here, don't really reflect the real world. In the real world, patients have comorbidities. They also receive treatments in a slightly different way. In a clinical trial, the treatments are given in a very prescribed manner, whilst in the real world, practitioners may vary what they do. Next slide. The Keratoconus Registry has been in operation since 2015, and ophthalmologists have been using it to track their practice. In particular, they've been looking at how cross-linking treatments have been working, but also reviewing whether patients with keratoconus are progressing. The data in the registry has been growing at around 30% per annum, and reports are provided for the practitioners after they put their data in so they can benchmark practice. This graph here shows you what the practitioner can show the patient during a visit. They can clearly see their progress in terms of vision and keratometry. Next slide. So we were hoping to find out with the registry some key questions for corneal cross-linking. You know, it does aim to stop progression of keratoconus, but from the literature, it's not clear as to what progression is and how best to measure it. We also wanted to know what was the best method for cross-linking and how we can avoid complications from the procedure. Next slide. What we found that over time, there was an improvement in vision and also a flattening of the keratometry. And this persisted from 1 to 5 years when it actually increased. Next slide. We did find patients that developed haze were younger and had steeper keratometry. This is important information as it allowed their treatment to be tailored and patients at risk can be counselled appropriately. Next slide. We've also used the registry to find out what's happened during COVID. And we found that a number of patients did not attend for treatment and they did not have cross-linking procedures. This has been important data as it's meant we've been able to go back to the keratoconus community and urge people to make sure they're having their regular checks. Next slide. So where are we now with the registries? Well, currently our real-world data is being collected across multiple countries. We have 8 countries using the registry with 88 practitioners. And from that, we're tracking what happens to cross-linking in the many different ways it's being performed. As although the clinical trials showed it should be done in a certain way, the developments in cross-linking have been happening at a more rapid pace than the trials first illustrated. And so techniques are being done in practice that haven't had the rigor of a clinical trial. We do now have some positive outcomes, including improved vision, stable keratometry, that have been sustained at 5 years with cross-linking, and we're still watching for COVID impacts ongoingly. The adverse events we've found are often late, and it's very safe in the short term. But long term, we really need to know what's happening over the lifetime of patients with keratoconus. A lot of the initial studies on progression were done using old forms of obtaining keratometry measurements, and these days there's modern equipment and we need to include that. And the most important group to include information from is optometrists, because they're responsible for the lifetime management of patients with keratoconus. Whereas cross-linking is a treatment that's done at a set time point, the patient then generally returns to the optometrist for further management, including spectacles or contact lenses. And having this outcome data is not only important for your practice, but it will help us answer many more questions on keratoconus, including its natural history and treatment. Next slide. Thank you. Next slide. I'd now like to introduce Mr. Larry Kornhauser. He's president of Keratoconus Australia. And in the registry, we collect patient-reported outcomes. It's a key part because we're very interested to know what the patients think. So he'll be talking about the patient perspective. Thank you, Larry.
Good evening, and thank you for joining the webinar tonight and showing interest in the registry project. Himmel invited me this evening to discuss keratoconus in Australia and what we do. But first, a bit of background. I was diagnosed with keratoconus at 12 and managed with glasses until I was about 18 when I started university. Then I suddenly lost all usable vision in my left eye and was hustled off for a corneal transplant. I spent 10 days in intensive care after the graft, watching many of my ward companions leaving under a sheet. Not pleasant. Back in 1971, my family received virtually no information about the disease itself, the prognosis, or the corneal transplant, other than that it was the only hope of restoring vision in that eye. The first we ever heard about contact lenses was once the grafted cornea was healing. Lenses for keratoconus were far from brilliant in those days, and there was pretty much only one fitter in town. But despite having lenses that regularly jumped from my eyes like popcorn, I managed on youthful exuberance and blissful ignorance of how much worse things could have been. Over the years, contact lens fitters and lenses improved, and I managed to complete my studies, work as an economic journalist, travel and live overseas. My graft began rejecting after about 13 years, and I received treatment in London and later Paris in the mid-1980s. I haven't got enough time tonight to recount the numerous trips to contact lens fitters and types of lenses I tried, the number of work days I lost due to scratched cornea, the expense of it all, and the despair I felt as things got worse and worse. On the bright side, at least I could enjoy a good eye rub every night after taking out those bloody lenses. Nobody told me about that either. By 1993, I was informed by multiple ophthalmologists who also fit lenses on keratoconus in France that my keratoconus was still progressing and I could no longer wear lenses. Bilateral transplants loomed. Older and wiser by then, I said no thanks and started the search for the world's greatest contact lens fitter. I found him lurking right under my nose in a leafy suburb of Melbourne. It was a watershed encounter in several ways. First, not only did he fit me with workable lenses, but he also broke the great taboo of keratoconus optometrics and gave me something I'd been requesting from optometrists for 25 years, a pair of glasses for when I couldn't wear my lenses. Why did he do that? Well, actually, because he listened to my needs and not his preconceptions about their usefulness. He also suggested I meet with some of his patients to consider forming a support group for people with keratoconus. I never met anyone with keratoconus in the 30-odd years since being first diagnosed, and everything I knew about it was learnt through hard experience. Despite all my own trials and tribulations, I naively wondered why people with keratoconus would need support. So I went along, but not sure what to expect. What I heard as each person told their own story that evening deeply shocked and moved me. a litany of debilitating hardship from vision loss, the difficulties of finding competent eye carers, of poor treatments, failed grafts, of poorly fitted contact lenses, and always the lack of information. A common theme was about not being heard by family, friends, and even worse, by those people paid to treat our vision loss. I heard that some optometrists thought that many of us had a keratoconus syndrome that made us angry and anxious and difficult to manage. We took up too much chair time and were always complaining about how our lenses hurt our eyes or we couldn't see with them. In short, we were patients to avoid if you wanted a peaceful, profitable practice. By the time the meeting broke up, I figured these people had good reason to be angry and anxious, and that maybe I should be too. So in the year 2000, Keratoconus Australia was born. We were ambitious and had no idea of what we were doing. I certainly didn't. I agreed to be president for just a few weeks, and 21 years later, I'm still here. So what do we do? Quite a few things, actually. We started Keratoconus Australia to deal with many of the issues bedeviling people with keratoconus, in particular the lack of reliable information, the impossibility of finding an expert contact lens fitter, and dealing with eye carers impervious to their patients' needs. Today we have almost 3,000 members. We're a tiny organisation operated by a handful of volunteers and funded by a few donations. But we've assisted many hundreds of individuals and families affected by keratoconus. We hold public information seminars, we've created a website full of resources, and we operate a helpline for patients and their families. We also support organ and tissue donation. Our main work, though, is in support. We try filling the gap, the gaping hole left by a medical system focused on dispensing treatments and unable to take the time to let patients express their hopes and fears about their rapidly failing vision. KC is a young person's disease. It's progressive and can move very fast, particularly in adolescence. It strikes just as people are embarking on their adult life journey, completing their education, entering the workforce, starting a family, or just trying to have fun without irritating parents around. And yes, today, cross-linking can slow the disease while contact lenses provide miraculous improvements in our vision. But even with those, as I often tell people, we're only a speck of dust or a flick of the eyelid away from disaster, especially if a contact lens pops off our good eye while we're driving or abseiling. All of us at Keratoconus have the disease and have been through the keratoconus mill. So when we talk to young people, we know exactly what they're talking about. It makes a huge difference to patients who inevitably have spent half their lives trying to explain to family and friends even the most basic issues, like why they need pesky, rigid contact lenses instead of soft lenses or glasses to see, much less why car headlights seem like spotlights and why we read in bed with a book pressed against our noses. Many of you would also know some of the other things we do in collaboration with the eye carers. For example, we help recruit patients for your research projects. We source volunteers for optometrist training clinics. We've collaborated with Melbourne University to run lectures for optometry students on keratoconus and to operate a keratoconus clinic that gives discounts to low-income patients while giving students hands-on experience fitting them with lenses. As the cost of contact lenses skyrockets, we constantly badger you to make contact lenses more affordable, especially for those low-income patients without health or pension cards, and to implement a consistent refund policy on unsuccessful fits. Cross-linking and the Save Sight Registry have been a big focus for us over recent years. When cross-linking first arrived in Australia and started being used on patients with very little evidence of its safety or efficacy, we threw our support behind CIRA's randomised trial of this new procedure, the first trial of its kind in the world. As more untested protocols were introduced and used, and sometimes misused, on juveniles, we advocated for more research to evaluate the outcomes of treatments, which were effectively using our members as guinea pigs. So when Professor Watson proposed the Save Sight Registry, I advised the association to support it as a means of finally tracking real-world outcomes of cross-linking procedures under various protocols and ensuring we were receiving best practice treatments. What I especially liked was that it was linked to a validated quality of life survey, or the KORQ, designed specifically for keratoconus. Both the registry and the KORQ are world first, I believe. Early data from the registry were critical in convincing the government to include cross-linking on the Medicare schedule in 2018, thus making this crucial but costly procedure finally accessible to thousands of Australians with keratoconus. And from the outset, we urged Professor Watson to include optometrists in the registry because we know you are our long-term carers. You restore the gift of sight to us, and you are the practitioners who will follow us for most of our lives and can best track our progress with keratoconus. Far better than our ophthalmologists who are too busy to bother with us once they've seen that their cross-linking has worked. So why should you join? Apart from the benefits to your professional development and practice, please consider this. When you join, you give your patients a voice. You give them access to the quality of life survey. You give them a chance to express their views in detail on how keratoconus affects their lives and how effective your treatments and management regimes are. Time constraints may have prevented you from having this interaction in the past. Through the registry, you can get this feedback in a standardised format that will provide an evidence-based means for you to trace the impact of your work on patients' welfare. And that seems like an incredible opportunity. The other side of the coin is that if you don't join up, you're denying your patients that voice. Most of us have been silenced for far too long to the detriment of everyone touched by this disease. And finally, in joining the registry, you'll make it far easier for patients to find optometrists working in keratoconus and who are committed to implementing best practice. Unlike many eye diseases, vision loss from keratoconus is fixable. That must be so rewarding for a practitioner because it is truly life-changing for a patient. Believe me, I wouldn't be here without my lenses. So please join up and help us improve outcomes for everyone. I think next up is Dr. Laura Downey. I've known Laura for many years and her CV is far too long for me to read out now. Also, I don't have it in front of me. The important thing is that she is passionate about keratoconus and improving optometrist performance in treating the disease, which is why I think she's a legend. Thank you.
So good evening, everyone, and thank you, Larry, for that really generous and kind introduction. So I'm going to run through some of the reasons why optometrists should consider contributing and kind of elaborating on what Larry has already gone through. So the optometry module has been launched and pilot tested and is an integrated system that links with the ophthalmology registry to ensure seamless patient care. So patients can be transferred between eye care practitioners. And as mentioned, optometry has such a vital role in providing long-term care to our keratoconus patients. And this includes then tracking the outcomes of treatments other than cross-linking, and in particular different contact lens modalities, so that we can understand how these work for our patients and also identify any potential adverse effects that are not being consistently documented in the literature. So currently we had a bit of a delay with the COVID-19 pandemic with registering users, but we have 17 registered practices and 16 individual optometrists who are already contributing data to the platform. This is a breakdown, so it's important to remember this is not just Australia, so we have New Zealand engaged and the potential to have international reach in several different countries, much like the ophthalmology registry over time. So we have an optometry steering committee as well. So that is co-chaired by Stephanie and myself. And you'll see a broad representation of clinicians here, many who will be well known to Australian practitioners for their expertise in fitting patients with keratoconus. And so we engage this group to have designed the elements within the registry to gain their feedback and make sure we're really meeting the needs of the optometry profession. So we're going to think about why an optometrist might want to contribute. And the first reason is that the platform supports reflective practice, and this will enable us to enhance how we provide care to our patients. So in contributing to the platform, optometrists can auto-generate clinical audit reports for key keratoconus parameters. So this might include visual acuity or corneal curvature over time. So this information enables us to continuously self-evaluate our management practices, and in a de-identified manner, we can also compare our individual clinical outcomes with those of our peers, as well as against national benchmarks. So as an example, optometrists who contribute to the registry will be able to determine how their patient's vision and also their patient reported outcomes change after interventions, such as certain types of contact lenses or even cross-linking, and also other factors like whether their patient's incidence of adverse events might differ from the normative population, and then to think about why that might be the case and potentially modify their own practice. Another important reason is for how we engage with our patients. So the registry allows us to graphically show our patients, such as in that diagram on the right-hand side there, their journey and their clinical journey over time. Key management strategies, such as contact lenses or any surgical interventions, can be tracked. And this can also be correlated with the measures on vision and quality of life for patients. So by doing this and engaging our patients in this way, it can help patient education about the condition and also potentially enhance compliance to certain therapies to demonstrate improvements in vision over time. The analysis of the data within the registry also in the longer term has capacity to assist with improving the overall quality of keratoconus care. So the registry essentially captures information about adverse events, and we've heard that with respect to cross-linking, but we can start exploring these types of questions within the specific scope of optometry practice, and in particular contact lenses. So as an example, we know there's renewed interest in larger diameter scleral lenses, and there's really no real world data to track outcomes, both in terms of safety, but also patient quality of life with these newer designs. So this centralized repository of data can be used to investigate potential associations between patient factors and clinical outcomes, and that has the potential in the long term to improve how we provide care to this patient group. Another important feature is that the registry has been recently accredited as an approved continuing professional development activity for Australian optometrists by the Institute of Excellence Optometry Australia. So for every 3 complete patient visits that are contributed to the registry, this will correspond to 15 minutes of CPD time. So it's rounded up to that 15-minute time point and will be calculated on a quarterly basis. And any data not used in a particular quarter can be carried over to the next round. And this really recognises that it is an important part of benchmarking and reflective practice to improve care. And finally, the registry provides unique capacity for optometrists to engage in their own real-world research as part of their daily practice. So as you contribute, you have the option to download and analyse, and if you're inclined to, even publish your own data if that's of interest, and participate in national and international audits. So this will help us improve our understanding of how keratoconus is managed in clinical practice, and also identify opportunities for how we might improve practice more broadly within the eye care professions, including optometry and ophthalmology. So I'm going to pass over now to Dr. Carl Campbell. Next slide, please. So Himal is the Kornhauser Research Associate at the Save Sight Institute at the University of Sydney. And he is really highly regarded for his research on how we measure and monitor and improve clinical and patient-reported outcomes across a spectrum of eye conditions. So I'm really delighted to introduce him and for him to share his expertise with you this evening. Thank you.
Thank you, Laura, for the introduction. Today I'm presenting on the research we do in the registry. First, ethics. Regarding ethics, we have received ethics approval from RANSCO for all private practices in Australia, and for any public sites in Australia or for any other overseas sites. The users have to lead the ethics application process, and we will support the users with the documentations, or for example, providing the research protocol. Coming to the publications, our publications are guided by the publication process guidelines. We have adapted this overall Save Sight Registries publication process guidelines to the Keratoconus Registry modules as well, and we will follow that for the optometry module as well. And there is a plenty of opportunity for the users to be involved as a co-author or as the or acknowledged as the FCB collaborator. And important thing to remember is that each clinician owns and holds the data they contribute. Now I will be discussing briefly some of the recent studies that we have done in the Save Sight Keratoconus Registry. These research have been done using the original module, that is the ophthalmology module of the Keratoconus Registry. But our goal is to highlight the potential to indicate what kind of research we'll be doing with the optometry module as well. The first one, looking at the vision-related quality of life in keratoconus. We found that in this study, we found that although a person's overall day-to-day functioning is determined mainly by the better eye, the vision in the worse eye may influence the quality of life and well-being. And clinicians should keep this in mind when treating keratoconus patients. In the next study, this is a review on clinical registries in ophthalmology, and the review highlighted the benefits of adopting disease-focused, good quality registries in clinical practice, and it showed a registry can drive improvements in patient care. And this review was published in the Ophthalmology Journal. This one is a meta-analysis which is also published in the prestigious Ophthalmology Journal. This study found that a closer follow-up and a lower threshold for cross-linking should be adopted in patients younger than 17 years and with steeper corneas. Another study which was published in Cornea found that Save Sight Keratoconus Registry could be used easily in clinics without affecting the total consultation time. This is again a review published in Cornea, where we evaluated the measurement of, evaluated all the studies exploring the measurement of quality of life in keratoconus. We found that Keratoconus Outcomes Research Questionnaire, KORQ, was the best questionnaire for evaluating quality of life outcomes in keratoconus. And this is the questionnaire we use in the registry, also in the optometry module. We then conducted a validation study to see how this questionnaire works in our registry setting. And the questionnaire worked really well. We supported the ongoing use of KORQ to routinely collect and measure quality of life data in keratoconus using this questionnaire. So this is a recently accepted study for publication, but it hasn't been published yet. This study looked at comparing the standard, which is also known as long method, and the shorter method. So we compared long and short methods of cross-linking for keratoconus, and we compared the safety and efficacy. We found that both the methods were similar in terms of safety and efficacy, looking at the 1-year outcome data. Currently, we are doing a longer term, we are evaluating longer term outcomes of these two protocols. The last one, this is also recently accepted paper in the British Journal of Ophthalmology. This study found that the steeper Kmax and younger age were the most clinically useful baseline predictors of keratoconus progression. We have also conducted several other studies, and you can see some of them here, and we have presented them in a number of conferences. And the areas we have looked into include evaluating adverse events of cross-linking and predicting the outcomes, and predicting and evaluating the long-term outcomes of cross-linking. Thank you for your attention. Now I would like to introduce the next speaker, Rob Medinsky. Rob is the project coordinator at the Save Sight Registries, and Rob will quickly demonstrate the Save Sight Keratoconus Registry, the optometry model of the registry today. Welcome, Rob.
Thanks, Amal. If you'll just bear with me for a moment. So this is sort of the view for the registries once the user logs into the system. And I'm just going to do a quick demo today. When users first request access to the registry, they'll also be required to do a brief training session just to cover the protocols for data entry and just to make sure that everyone is understanding of the importance of getting the data correct and the fact that this is a research registry, so we need to ensure that everyone is using it correctly. So I'll just do a quick demonstration now. Once you've logged in, we're over here in the patients panel, and you can see this is my practice here, Optom practice, and all my patients here. I've only got one patient at the moment, but I'll click new patient to add a new patient into the registry. And I'll select corneal optometry, and myself, test optometry as the primary clinician. So this will generally be the optometrist for the patient. Any other optometrists that are also seeing the patients will be marked as secondary clinicians here. The primary clinician is considered to be the owner of all of this data that is being entered. The patient identifier should be an identifier, a series of numbers and or letters that do not immediately identify the patient. So just an EMR number is perfect for this. And we ask users not to enter any date of birth for the patient or any names for the patient. So just an EMR number is perfect for that purpose. You'll select an ethnicity. If you're unable to specify, there's an option for that too. A gender for the patient, year of birth, and postcode and smoking status are both optional fields, so they can be entered if you want to, but they are not compulsory. Then the age of keratoconus diagnosis, and if it's not known, there's an option for that too, and family history as well. So if there is family history, you'll be asked to specify the kinship for that family history, so maybe it's the parent as well. And then once we're happy with that, we can click create, and this will take us straight into this patient's page. And you can see here there are a couple of options across the top here. New visit, new questionnaire. We can go back in and edit any of those details that we did, or we can refer the patient as well. So I'll just go quickly and click new visit to create a baseline visit for this patient. I'll also bring back the date a little bit, just so that we have room for a follow-up visit as well, just so I can show you that as well. We only allow one visit per patient per day in the system. So if yeah, you'll need to just record one per day. So by default, you'll have to include both eyes in the audit. But for this example, I'll just do the right eye. But if you were doing both, you would tick to include both eyes in the audit. So you specify what ocular conditions the patient has, if it's just keratoconus or if they have comorbidities. The prior management that they've been using, so maybe they've had some type of spectacles or lenses in the past, so we'll just say spectacles. Whether they've worn contact lenses in the last 24 hours. The cone morphology, and clicking on this little document icon will sort of give you a bit more information about what we're looking for here. Then we'll look for habitual VA, and this can be recorded either in logmile letters or in Snellen, or Snellen as a decimal, and that's specified at a practice level. So I've just got it in logmile letters here, so I can just make my selection, and there's also a visual acuity conversion chart that can be specified here. So I can say that this was unaided. This is my pinhole visual acuity. And this is the best corrected visual acuity. So let's just say that we were able to achieve this with spectacles. And then we will be asked for spectacle refraction and the vertex distance there as well. So we'll make our appropriate selections. And also, if there are any values that are entered that are too high or out of the range, then the system will prompt you to specify a more appropriate value there. And we also have the option to enter a sphere only here as well. So that'll just get rid of these last two cells for you. We'll do the vertex distance here as well. So again, I've gone out of the value, so we'll just put that in there. Kmax as well. And there is some documentation here just to show you where Kmax can be found on some of the more common OCT scans. The thinner spirometry, and whether the patient has had any adverse events. And this is assuming if the patient has been transferred from another practice, maybe they've had cross-linking in the past, then they might have one of these adverse events. Yes, I'll just say no for now. Once we're happy with that, we can do two things, either save or finalize. So saving just records everything that we have here, and it assumes that it's incomplete data, and we can come back in and finalize it later on. Finalizing is what we're looking for, and that's going to run a quick validation on all of these fields, make sure that we've got all the correct values in there, and then we will also consider that visit to be complete, and then that data could potentially be used for research in the future. But we will never use saved visits for research purposes, because again, it's considered to be incomplete and therefore unreliable data. So we'll finalize that there, and you can see that's being recorded there as a baseline visit. So I'll just quickly show you what a follow-up visit looks like. You can see it's quite similar. It's just got slightly fewer fields. It doesn't have those initial fields there. And again, we're going to look for some similar fields here. So I'll just quickly put some values in here and look to do the same, finalize the visit there. So there you can see we've got a follow-up visit, and we started to plot this eye on the graph down below. And if we had the left eye included as well, you'd see that there as well. So the next thing to show is what Larry mentioned, the KORQ questionnaire. So clicking new questionnaire will take me into this page. And there are a couple of ways to enter this questionnaire. You can either sit with the patient and enter it on the screen like this, just filling in each of the boxes. There's also a printable version that's available in the support materials section over here. Or we can send out this questionnaire via an expiring email link. So this link is only available for one use and for 14 days. So you can just copy paste this into an email and send that off to the patient, and then they'll have their own little portal that they can go into, and it'll just click through and they'll be asked each of these questions, and then it'll automatically be populated into the registry. So that can be a great way to provide patients with access to the registry. Maybe if they're in the waiting room, you can get them to do that on their own device, and then discuss that with them in the room, or you can do that in the room with them as well. So that is the questionnaire. Then there's also the option to create a medical history form, and we're looking here at systemic events and medical conditions as well that can potentially impact the keratoconus or the cross-linking if they're going to have it. And the last thing to show here is the referral patient. So this module was actually developed as a companion module with the keratoconus module. So I've actually got a referral here waiting for me. You can see that by the red one there. So this is a patient that's been referred to me from a keratoconus practice. And if I click accept on that referral, it'll actually bring that patient to me, and it's already pre-filled at some of these fields here based on that existing patient record. So I'll just fill in the blanks. I'll give it my own identifier for my own practice. And once I've clicked save patient, you can see here that's already populated with the existing fields from that other doctor. So they've sent me this patient with existing history for the patient. And now what I can do is create new visits. The first visit that I create will be a new baseline from my practice. And this will also be populating the same graph that the patient was on, that was below, sorry, the same graph there. So I'll quickly do this right eye just so that we can see that on the screen. I'm just wary of time here. So you can see here, there's my practice, there's my visit that I've just created, and you can see it's being populated here on the graph below. So you can see I've doubled up on the on the dates there, but basically that's how you'd interact with the same patient, and you'd both be contributing to this same patient graph below here. The last thing that I will show quickly is the support material. So this is the opt-out patient flyer that can be accessed from the registries. And there's also that printable version of the KORQ here, and a couple of other important documents, an information brochure on corneal cross-linking that was developed by Keratoconus Australia. So there's some great information there as well. All right, I believe that's my time. I don't want to keep everybody too long. And as I said, when a new user is entering the registry, they will do a short training course that will cover some of that information that I have there, but then give you a bit more detail there as well. So what I'll do now is pass on, and I believe Pauline, who is up next, and I will let her.
Thanks,
Paul. Oh, sorry, it was Stephanie, my mistake. Paul.
Right. Pauline's popping up the slides. I'd just like to remind everyone, if they've got any questions, to please put them in the Q&A box, and we'll get to those at the end. Now I'd like to launch the Dry Eye Registry. So based on the success of the Keratoconus Registry, we've now developed a registry to collect everyday outcomes on patients with dry eye. And this is because, as you all know, dry eye remains really common, and many patients continue to suffer despite there being this range of available treatments. So we wanted to learn more about dry eye, but we also wanted to help practitioners manage dry eye patients in their practice every day. I'd like to now introduce Pauline Koo. She's the project officer for the Dry Eye Registry. She's just completed her PhD and works at the Save Sight Institute. Thank you, Pauline.
Good evening. I thought I'd start with a little bit of background of why we developed the Dry Eye Registry, where we're at with it now, and what our future plans are. So the prevalence of dry eye disease worldwide ranges from 5 to 50% in the adult population. And we know that it can significantly impact a patient's quality of life despite the availabilities of multiple treatments. Currently, gaps in the literature exist due to the lack of universally accepted criteria to assess disease severity, disease indices, disease activity, and also treatment efficacy. Now, clinical trials are effective in determining the efficacy of new treatments. However, they do not represent the general population, and they're generally conducted over shorter periods of time, from anywhere between 3 to 6 months. We're seeing clinical registries play significant roles in healthcare decision-making, and this is because they're designed to collect real-world data and clinical information in a systematic way, and they're also able to collect it over longer periods of time. We looked through literature and identified that the ideal registry would be multinational, interdisciplinary, use a secure web-based platform, have a minimum but mandatory set of data fields for clinicians to complete, and also include patient-reported outcome measures. So we're fortunate enough to receive funding by Novartis, and we put together an international steering committee of ophthalmologists and optometrists from around the world. So they included countries such as Spain, France, New Zealand, Australia, Germany, and the United Kingdom. So the Dry Eye Registry was launched on the 18th of December 2020. Like the keratoconus optometry module, it received approval for private practices with opt-out consent from RANSCO. So what the opt-out consent basically means is as long as you inform the patient of the registry, you can include them into the registry unless they give you express consent or express decision to actually be excluded. We also received approval for CPD points from Optometry Australia, as Laura would have mentioned. So basically, for every 3 visits entered, you are awarded 0.25 points. So if you enter 12 visits, that's 1 point. To date, we have 17 users registered from 12 practices in 8 countries using the Dry Eye Registry. So the Dry Eye Registry is made up of mandatory and non-mandatory fields. So on the left-hand side, these are all the mandatory fields, and the right-hand side will show you the mandatory and non-mandatory fields. So the mandatory fields should be tests that can be performed in all optometry practices, while the non-mandatory fields may depend on the instruments that you have in your practice. So the data entry for baseline and follow-up visit can be entered within 2 minutes for the mandatory fields, and for all fields, that is mandatory and non-mandatory, it can take up to about 3 minutes. We also included patient-reported outcome measures in the dry eye registry, similar to the Keratoconus Optometry Registry, but in the dry eye one, we have the Ocular Surface Disease Index, the Ocular Comfort Index, and the Patient Health Questionnaire. Now, we do recommend at least one of the questionnaires be performed during a patient's visit. So the dry eye registry can collect these questionnaires in a few different ways, as Rob would have mentioned. You have the hard copy, so you can either give this questionnaire while the patient's in the waiting room. It would require the optometrist or an optical dispenser to then enter the patient's responses into the registry. You can also, if you have an iPad or a computer lying around, the patient can enter their responses in and would go straight to their record. As Rob would have mentioned as well, you can email the patient the questionnaire, and this would actually allow them to, if they're in the waiting room, access it through their phone and enter their responses, or do this at home at a later date. So some future plans that we have for the dry eye registry would be changes to the graphical outputs. Currently, what it shows is the visual acuity in logMAR and also treatments given. Now, we know that for dry eye patients that they often do report of visual disturbances such as blurred vision. Normally, when we do normal visual acuity, they have normal vision. So what we plan to show is key dry eye outcomes. So this would include tear breakup time, corneal staining, and also the Ocular Surface Disease Index score. We also plan to include the clinician outcomes report, as Laura would have mentioned. It would be very similar to the keratoconus module, and this is going to allow you to reflect on your patient's outcomes and benchmark them with those of your peers, not only in Australia, but also ophthalmologists and optometrists from around the world. So that brings us to the end of our webinar. I want to thank you for your attention. If anyone has any questions, you can put it in the chat. And if anyone's interested in joining, the website is up on there, and you just have to request access to be able to access the registries.
Thank you, Pauline. I'd now like to ask all the panelists to please put their cameras back on in the event that there's some questions, and we could unshare the slides. We do have one, so if anyone has questions, they can pop them into the Q&A. We have one there about if we fill in the vision at the final aftercare or during each visit when we're in the process of fitting. With the registry, you can enter as many visits as you like. And so for patients after cross-linking, I'll enter their data each visit so I can see their progress. So similarly with, it could be urgent, but perhaps Laura, you'd like to comment more about how that would work for an optometrist.
Yeah, I think it would be the same principle for optometry. So pretty much as you've said, I think really nicely. Yeah, so you can't, I think that summarizes it well. Unless there's a follow-up question, happy to answer.
The other question we got was about sort of how the all sort of data and privacy works. And so when you're putting in your own data as a practitioner, nobody else can tell that that's your data. So once the data goes into the registry, it's completely anonymized for practitioners as well as patients. But for your own practice and your own patients, you'll be able to see the patient when they come back, you'll be able to get their data up through their patient identifier that you give them in your own practice. And then you'll be able to benchmark your practice against the rest of the registry. And in all of that, you will be anonymized. The investigators, the investigative team and the steering committee are not allowed to know which practitioners are putting in the data. So that's all masked to the investigators. So it's completely private for you to put your information in. Good. There's some more questions. So somebody was just asking whether they need to have a pentacam. Laura, do you want to comment on the optometry topography?
Yeah, so it's certainly not essential. So we've had input from many optometrists to try and ensure that the parameters we assess are going to be accessible by the vast majority of practitioners. So they essentially look at keratometry or Kmax and other standard measures. There are some optional parts of the registry, but we would expect the vast majority of people or clinicians managing patients with keratoconus will have the core data set that's required.
Pauline, there's a question there on the dry eye registry about the conjunctival inflammation. Is it mandatory? How is it measured?
So the conjunctival one is, so there is with the dry eye module, and it's also with the keratoconus module, there is actually tooltips when you access the registry, and it'll help you actually measure them. For this one, it's using the, I think it's using the, similar to the Brian Holden grading system. So it'll actually measure it via, it's like either non, mild, moderate. So there is images like tooltips to actually help you grade these.
And then we have a question about what sort of patients to put on. Is it any particular type? Well, the beauty of the registry is that it's not like a clinical trial, so it's not restricted to a certain type. You can put any patient with the condition, either keratoconus or dry eye on, that you want to track and review the outcomes of that patient in the practice. And then Jason is asking about the long-term goals of the registry. Why this all was set up was really to improve patient outcomes. There's research that shows that benchmarking can improve the outcome for patients by bringing all clinicians together and enabling them to review their practice. At the moment, there's a wealth of knowledge in clinical notes all around the country and around the globe. Practitioners are writing notes in their files, their patient files, but that data never gets to see the light of day and inform practice. So what we're trying to do is really, improve outcomes. And if that does involve getting a new Medicare item like it did for cross-linking, then we consider that, worthwhile. We consider research publications worthwhile. We consider just improving patients' practices and practitioners' practice and providing CPD accreditation worthwhile. We also are interested to hear from anyone that's using the registry if they have a project they'd like to pursue or a research paper they'd like to write. They can contact us and we can help them with that through that process. Do you want to say any more, Laura?
No, I think that summarizes it beautifully. And as we've mentioned in multiple talks, this capacity to measure patient-reported outcomes, to really understand what the patient experience is like, is something that the registry facilitates in a way that allows tracking over time in a meaningful and quantitative way. So at the moment, we obviously try and engage with our patients and try and gauge how therapies or contact lenses are working. But this provides a platform for doing that over time and in a way where we can see whether things are improving or not. So that's a real advantage, I think, for both patients and for clinicians to understand the patient experience much more readily.
Larry, would you like to add to that?
There's not much more to say, but, your answer was probably the obvious one. It's to improve patient outcomes. I mean, everything you should be doing is to that goal. That's why you do what you do. That simply is the importance of what you're doing and why the registry is going to help. As Laura said, you're suddenly getting, a standardized evidential sort of body of data to show you whether you are improving people's outcomes or not. It's fantastic.
Himal, would you like to comment on the consent? There's a question there about it being, opt-out. Do you want to explain how the consent works?
Mm-hmm. Sure, Stephanie. So in Australia, the RANSCO has approved the opt-out consent form, and then the opt-out consent form means like if a patient is not happy to be enrolled in the registry, then he has to sign. They have to sign, and we keep it in our records. But if they are happy, we provide them the information sheet, and then if they are happy, then they don't have to give us anything. So they only sign if they are not happy to be in the registry. That is the opt-out consent form.
And we're happy for that consent form to be branded. Like if you've got a practice branding, that we can put logos into that, so it's personalized for your practice. I mean, I've not really had anybody say no. Most patients are quite keen about it. I found particularly that with the dry eye registry, there's the patient-reported outcomes, and I'll ask Pauline to explain which ones in a minute, are very useful because the patients are filling them out, and then when they come back next time, we can tell more accurately how they're going from a symptom point of view. Pauline?
Yeah, so we have the ocular surface disease index and the ocular comfort index. Now, obviously, you don't have to get the patient to do both, but it is helpful to actually know that. Like I said, for the graphical output, we want to actually show that at some point in the future, because it is helpful to see the symptoms, whether these patients are getting worse or better with the treatments that are provided. Also regarding the opt-out consent though, as Stephanie was mentioning, so we do actually have it in the support system, as Rob would have shown. There's the part where you can actually personalize it to include your practice logo into it as well.
Thank you. And then somebody's asked about the postcode and whether that's identifying it. Look, the ethics committee has not considered it identifying. Keratoconus and dry eye are very common, and we actually collect year of birth rather than date of birth. We don't collect the names, and so it's not considered to be identifying. Okay, just reading another. Yeah, so if the patient says no, we can't enter their data. That's in response to another question there. And then we have one asking how, dry eye is very common. So what sort of dry eye patients should we put into the registry? And we have, for CPD, we have sort of encouraging practitioners to put at least 80% of their patients in. I'm finding it quite useful for patients that I think will come back and that I'll be engaging in their ongoing management. But as I was saying before, there's no sort of strict inclusion and exclusion criteria. It's patients that you're seeing with dry eye that you're going to commence treatment or that you are reviewing. Laura, do you want to make any comments?
Yeah, I think that we're interested in capturing the spectrum of dry eye disease. So even those with mild disease, we would encourage those to be entered, and that will also allow us to kind of understand the natural history and how disease might progress or change over time. So there's no restriction on the level of disease. We'd be encouraging a really diverse range of patients to be contributed.
Thank you. So we're coming up to the end of the hour. I'd like to thank all the attendees for spending their time with us. I'd like to thank the panelists for doing an excellent job. If you have any questions afterwards or you want to follow up with us, please do. We'll also be reaching out with you for an evaluation form about the webinar, so we can hopefully provide more sessions in future and cater to your needs.
And just before everybody leaves, I'd just like to share how to request access to the registries. So you can access it through frbresearch.org. There's also a link at savesight.registries.org, and then clicking request access and filling in this request access form will connect you with the Save Sight Registries team, and we'll be in touch to organize that training session with you.
Thank you. Thank you, Rob. Thank you, everybody. Good evening.
Thank you.